Hello everyone and good afternoon. Thank you for your participation in today's webinar. I would now like to pass on the call to John Auerbach, who will be the moderator for today. John, go ahead please.
Thanks very much, Maria. Good afternoon, everyone, and thank you for joining us today for this webinar on health IT to improve STD services and strengthen ties between public health and primary care. Today's webinar is part of an ongoing effort by several organizations to encourage active consideration of and steps towards integration of STD services into primary care settings as part of the changing circumstances for local, state, and national governmental public health. As you heard, my name is John Auerbach, and I'm a professor at Northeastern University and the director of the Institute on Urban Health Research and Practice, and I'm also a former state and city health commissioner. Our institute has received funding from the Association of State and Territorial Health Officials to assist local and state health departments to consider stronger linkages between public health and primary care. And these efforts are occurring in conjunction with the National Association of County and City Health Officials, or NACHO, the National Association of Community Health Centers, and the National Coalition of STD Directors, and all of these efforts have been generously supported by the Centers for Disease Control and Prevention. We're grateful to ASTHO, CDC, NACHO, the National Association of Community Health Centers, and the National Coalition of STD Directors for your support. Last year, 10 teams from across the nation were formed to assist in the consideration of the optimal ways to integrate STD services within primary care. And these teams represented both local and state department officials as well as leaders from community health centers and state primary care associations. And the teams participated first in a survey, and then we all came to Atlanta for a 2-day meeting in August. After the meeting, we surveyed those teams regarding the progress they'd been made, and we also asked them what type of additional support, training, and technical assistance would be most useful for their continued work. When we did, 2 topic areas were identified as important for webinar presentations, and the 2 were, first, taking advantage of the emerging efforts to tap HIT for the management of STD screening and treatment, and for linkage of public health and primary care efforts in STD work. And the second one was taking steps to guarantee confidentiality in the provision of STD services in primary care with alternative policy and programmatic approaches. Today's webinar is going to be focusing on that first topic. And on Friday of this week, we're holding an additional webinar to focus on the second topic. You're all invited to the Friday webinar as well as today's webinar. That Friday webinar will be at 1 o'clock Eastern Standard Time, and we're going to send a follow-up email to everyone who's participating in today's webinar with the registration information and linkage, and we hope you'll join us for that webinar as well. For both of the webinars, we've invited the members of the 10 teams that I'd mentioned previously. But in addition, because we believe that the topics were of broad interest, we've invited other STD directors, health officials, and community health centers to join this call. Both today and Friday's webinar will be recorded, and both will be made available on the ASTHO website. By the way, please feel free to invite others to register for Friday. It's completely open to anyone who would like to participate. Now let me share with you the format for today's call. This call will last until 3:30, and we're delighted to have 3 outstanding speakers who will share their perspective on the potential to use health IT to manage public health generally, but with a particular focus on its utility in managing STD services and the linkage to primary care. After the first and the third presentation today, we're going to open the floor for questions, and you'll have an opportunity to either write a question or ask a question verbally. As you're hearing the presentations, we encourage you to consider the questions you'd like to ask or the comments you'd like to make so that you're ready to make them when the opportunity arises. After the first and the third presentation, Maria will offer you instructions about how to offer your questions or comments, so please be prepared to jump in when that happens. And now it's my pleasure to introduce our first speaker. Our first speaker is James Daniel, and Jim is the Public Health Coordinator for the Office of the National Coordinator for Health IT, or as it's known, the ONC. Jim has been in that position since 2011. He holds an MPH from Boston University and a BA in microbiology from the University of Texas. And before joining the ONC, Jim worked for over 10 years in the Massachusetts Department of Public Health, where he served as the Chief Information Officer during the last 4 years of his tenure there. Luckily, I got to work with him in that job. Previously, Jim served as the Director of Informatics for the Bureau of Communicable Disease Control, and he was the Health Alert Coordinator, and he served also as an infectious disease epidemiologist. So in addition to working at the national level, Jim really understands the conditions and challenges of working in a state health department. Jim's going to present to you a brief update on what is happening with meaningful use as it relates to public health, and then the majority of his presentation is going to focus on how the ONC sees the future state of data exchange between healthcare providers and public health. And again, he'll have a focus as a part of that presentation on the particulars regarding STD. Jim, it's a pleasure to have you join us.
Thank you, and thank you, John, for the invitation to present. I'm pleased to be able to present to this group. And as John mentioned, I'm going to be doing a brief overview of the Meaningful Use program and how it ties to public health, but then really spend the majority of the discussion on the future of health IT and integration with public health departments. But just to sort of frame the conversation and hopefully really frame the questions and answers at the end of the presentation, I want to think about just where we are today with STD services and health IT. I think most people know this, but for STDs and a lot of the infectious diseases that we work with in public health, there's still a wide variety of how healthcare providers send information to health departments. We might get a lot of the lab information through electronic lab reports from our large commercial labs like Quest, but we still get a lot of the clinical information from our providers via fax and paper and STD-specific software provided by CDC, which calls for a lot of manual data entry. And then the health department does a lot of work to clean and analyze this information, and then that allows for the information to be sent on to CDC, where it is aggregated nationally and reported out through MMWR. So because of the way this current system works, it really means that we're spending a lot of time on manual data collection, that maybe sometimes we have paper reports sitting in piles, and because we can't even prioritize those paper reports, especially for STDs, the ones that could really benefit from investigation sit at the bottom or in the middle of the pile where we can't prioritize them and work on them. So the idea here is to really help figure out how we can help with that and create IT systems that are able to speak with each other and to integrate better with the EHRs so that we can actually allow STD services within the health department to spend more time on prevention and outreach and less time on data entry and have the information needed to prioritize cases and target high-risk populations, and to really take advantage of the electronic health records that are out there and have that information more integrated electronically with the public health department. So that's how I hope to frame our conversation today. You'll hear me talk a little bit about more high-level general health IT projects, but we really want to bring it all back to how it can help STDs in our conversation. So I did want to do a quick update and background on the Meaningful Use Program. I think most people are aware of the Meaningful Use Program that we have with our office, ONC, in collaboration with CMS, that actually has several different phases. Stage 1, which started in 2011, Stage 2, which just recently started in 2014, and Stage 3, which probably now start in 2017, not 2016. But I do want to remind people that each of these stages have different outcomes associated with it. Stage 1 was really about just capturing the data. Stage 2 is really about advanced clinical processes, and Stage 3 in 2017 is when we really expect to start seeing those improved outcomes. Sometimes I think people think that we're supposed to start with improved outcomes in Stage 1. So just a quick reminder that we did have these stages on purpose. I do want to let people know that there is great progress in getting both eligible professionals and eligible hospitals signed up with electronic health records. The numbers keep going up daily. The numbers on this slide are a little bit old. We're very actually close now to reaching our goals of 500,000 providers. In July of last year, we were at 78%. And on the eligible hospital side, we're doing even better, close to 90% of hospitals registered last year and even closer to 100% this year. So just remember, in this world that we're working in, almost every provider that public health is going to be dealing with is going to have an electronic health record that we can interact with as public health. And a quick background, too, on some of our grantees. We don't just ask providers and hospitals to install these electronic health records and leave them on their own. We actually have what we call regional extension centers to actually help providers, especially the small provider offices, implement their EHRs, figure out how to transform from a paper-based practice into a fully functional EHR. And part of the services that our RECs offer are actually how to better integrate with public health. So that's part of our guidelines to our grantees. We also have health information exchanges that have been developed across the country as well. Their grants are just now winding up, but they developed a lot of infrastructure within their jurisdictions that enable the health information to flow from provider to provider and from provider up to hospital, up to public health departments. And again, part of our guidelines to our grantees were to ensure that the HIEs, the health information exchanges, were connecting health departments. And we've had a lot of great success in many of our jurisdictions, and I see some of them on the call today, who actually have been able to really help our health departments connect with the providers within their community. So just some of the things that they've been doing, helping with e-prescribing, helping with electronic lab reporting, and again, helping with public health. So just kind of a quick review of what some of the measures in the public health arena were for our Meaningful Use program. In Stage 2 Meaningful Use, providers were required to connect with immunization registries, both ambulatory and hospitals. Hospitals were required to submit electronic lab reports to public health. Hospitals were also required to submit syndromic surveillance. That's data from their emergency departments to help look at emerging infectious diseases. Some ambulatory cares chose that as a menu set option as well. And then there were two other menu set options for ambulatory care providers around reporting to cancer registries and specialized registries. So again, not anything specific to STD in Stage 2, but we do have electronic lab reporting, which actually does help, I think, quite a bit with STD reporting. If we look across the country at the lab volume received via ELR, it's going up every quarter that we measure, and we have more and more information coming in via ELR. And if we look at the volume of lab reports and for percentage via ELR, we can also see that for STDs, that the percentage of lab reports coming for STDs is going up on an annual basis as well. And as more and more hospitals start to choose electronic lab reporting, or as they start to implement electronic lab reporting as a core measure in stage 2, we're going to see this number go even higher. So again, although there wasn't anything specific around STD reporting in stage 2 meaningful use, the electronic lab reporting did really help public health, I think, a lot in increasing the number of lab reports that they were getting electronically for STDs. But one of the things that I really want us to think about on this call is really beyond meaningful use. What are the strategies to effectively engage public health to integrate with electronic health records and to really promote that interoperability between electronic health records and public health? Because remember, what we want to do is really figure out how we fix some of these issues with what's going on today, where we get lots of paper and faxes, have systems that don't talk to each other, and we want to, again, have more time to do the things that we really need to do at the health department, spending time on prevention, outreach, partner notifications, a thing that public health is really good at. And we need to prioritize those cases so that we can target the right ones. What is it that we need to do to start planning for that? And that's the goal in mind that we should have as we figure out how to promote interoperability between electronic health records and public health. So as we think about going on beyond meaningful use and what's going to happen even after stage 3, we actually have an initiative at the ONC called our Standards and Interoperability Framework. And within our Standard and Interoperability Framework are several initiatives that I think have a lot of relevance to public health. But the really nice thing about these initiatives is that they are not specific to public health. These initiatives are about overall interoperability, or the ability to exchange data with electronic health records. And these types of infrastructures are being built not just for public health. They're being built for clinical research. They're being built for interactions with FDA. So it really behooves us in public health to figure out how we work within these standards, because these standards for interoperability are going to happen with or without public health. And it's really up to us to start defining how we fit into this new world. And so we've developed at ONC, within our Standards and Interoperability Framework, a very specific initiative that we're calling the Public Health Tiger Team. And we are looking across all of the standards within the S&I initiative and picking out the ones that we think play a particular role in integrating public health with EHRs. And we are building our business cases, documenting exactly what we would like to do to make sure that the standards that are developed within the S&I framework really meet what public health needs to do. So it's really important to get groups like you guys involved so that we can make sure we understand what the business needs to do as we develop the standards, to make sure that these standards really accomplish what we're trying to accomplish. So I'm going to go over a few of our initiatives and where they intersect with public health, talk a little bit about where I think they might intersect directly with STD, but then again, I really would like to start hearing some of your ideas about where the crossover with STD reporting is as well, and invite you to join our Public Health Tiger Team, which I'll talk a little bit about at the end as well. So our first initiative, our set of standards that I want to talk about, is called Structured Data Capture. And I know this is a really scary slide, but I like to put up pretty slides when I talk about this, so that you have something to look at to kind of understand what I'm talking about. But it's not nearly as confusing as it looks. And I'm going to give you an analogy before I start to describe what structured data capture really accomplishes. So I'm going to assume that most of you have shopped on a website to purchase some product, some retailer that has a website. And you go through and you shop and you add things to your cart, and then you get to the point where it's time to pay. And many of these websites now have an option that says pay with PayPal. And you can click that button, and within that retailer experience, the PayPal experience is brought up. And you can confirm your payment methods, confirm your shipping address within PayPal without ever really leaving the retailer's website. And once you complete that part, you're bounced right back into the retailer's website. And it all happens seamlessly. As you go to PayPal, PayPal knows how much you're expected to pay. PayPal knows how much the shipping is. Your credit card is charged the right amount. When you go back into the retailer's website, all without really switching tabs or ever having to, really move to a different website, the retailer website knows that you've paid, and it knows where to ship the information. And that all happens from what we call a set of services that are defined between PayPal and those retailer websites. And there's a set of standards that PayPal publishes that says, if you want to interact with us, here's what we expect you to send us, and here's what you can expect us to send back to you in these very specific formats. And it allows that interaction to happen. And that's really what structured data capture is about as well. And the EHR analogy here is a lot of different people, from clinical research to FDA to public health, all have data elements and forms that they would like to have filled out. And instead of asking the EHR vendors to put all of these forms directly into their EHR products, we can sort of act as a service, as a third-party service, just like PayPal acts as a third-party service to retailers, and provide forms back to an EHR. And the great thing about it is, on the forms, what we call the forms manager side, which in our case is going to be public health, we get to hold and manage the forms. So if all of a sudden we need to ask a new question, like if MERS were to become a big deal in the United States and we needed to ask everyone with flu-like illness where they had traveled, we could add a travel question to a case report for something like MERS, and EHR vendors wouldn't have to go back and add new data fields into their system. It's just going to be available because they're interacting with our forms manager. So the idea, again, here is an EHR could call out to someone like public health saying, I have a case of a potential MERS to report. The public health forms manager sends back the form that needs to be filled out. It's filled out within the EHR, just like the provider never left their EHR, gets pre-populated with all the information about demographics, address, name, all that good stuff, just like PayPal gets pre-populated with what you're purchasing. But then there's some additional information that might get filled out before the information gets sent back to public health. And I think a really good way to think about this for STDs would be case reporting for STDs. We saw earlier that we're getting a lot of good lab information through ELR around STDs, but we really need that clinical information to prioritize the cases that we really need to do investigation on. And you're not going to get information like treatment status and pregnancy status from an electronic lab report. That's something that we could do with structured data capture, where when a physician knows they have a case of STD to report, it could actually pull up the appropriate form, get pre-populated with all the information, the demographic information for reporting, and then the information that might not be readily available within the EHR, like treatment information and pregnancy status, could be questions that the physician then fills in the form before it gets sent on to public health. And you can imagine that maybe we would get a lot more complete information than with the old MORB cards or case report forms that physicians would have been expected to handwrite out and send back in to public health. So that's one of the, I think, really exciting new technologies that we're talking about is in our S&I framework is structured data capture. I think there are a lot of really exciting ways that we could integrate with public health. You know, there's very much a standard for how to do this so that if we do it once, we can do it with every EHR product that's going to be out there. Because remember, these EHR products are going to be doing this exact same type of technology for things like clinical research. It's just different questions and forms that public health would have. The technology will all be the same. We've had some exciting pilots happen, including one in New York City that we're going to hear a little bit about later. We're trying to do some more around early hearing detection, intervention, cancer case reporting, and I would love to see some pilots, especially around STD, because I think the return on investment for STDs for this would be great. So the next S&I framework initiative that I want to talk about is called Data Access Framework. And Data Access Framework is really all about the idea that data within an EHR should be open and available via a standard format. Right now what happens is there are very proprietary ways that data is stored within an EHR and very proprietary ways to access it. So if a physician wanted to create a simple report out of their EHR for, say, people with diabetes who have A1Cs showing that their diabetes is not under control, they'd wanted to generate a report like that so that they could do some targeted interventions. That's something they'd actually need to go and pay their very specific EHR vendor to do. And those costs can start to add up substantially. So the idea here is, under our local access query, is that a provider could actually do these kinds of things themselves if they had the capacity, or perhaps hire a third party to do it instead of having to rely on their own particular vendor, and create a little competition so that maybe those costs aren't as high. But I think the really exciting part about Data Access Framework is the third column that you see, which is multiple data source access or a distributed query. We sometimes also refer to this as query health. And the idea of query health is it allows a third party like public health to query across multiple EHR providers, bring that information together in an aggregate format, and look at population health measures. So it's really the standards that allow for someone at a health department to ask sort of the same questions that a provider might ask. Who within my community, instead of who within my practice, has a diagnosis of diabetes and has A1Cs that are greater than 5? And since I'm public health, I'm not interested as much in the individuals, but I would like for that to be aggregated by race and geography. So this is the type of technology that could allow public health to go out and query across every provider within their community, bring back those aggregate numbers, and have a real population health measure to help start profiling their communities and identifying risk factors. So again, it's just a set of standards that allows this to happen, standards that public health would need to use to send a query out, and standards that EHRs would use to send the results back. And we actually have some really great pilot projects going on doing query health in both New York City and Massachusetts. In New York City, they've done some initial work just around BMI, and using this query type model, they've been able to identify geographies where BMI is more of an issue than in other neighborhoods. And I know there are lots of epidemiologists on the call, and you're thinking, well, what about BRFSS and other data sources that we have that already give us this information? And I think Now, the way to think about something like data access framework and query health is this is another tool in our tool belt. This is another way that public health has to get access at what's going on in their community. I don't think there's ever going to be just one way that public health gets population health measures. This is just another way that we could have to try to figure out what's going on in our communities and put the data together with other data sources that are available to us. There's another active query health pilot in Massachusetts, and they've done some initial work around ILI visits, trying to look at flu vaccinations and ILI visits. So they've used it for infectious disease, but they've also looked at gestational diabetes. And they were able to actually, through this technology, actually identify specific parts of their population that were at higher risk of developing gestational diabetes. And then they were able to develop some outreach campaigns specifically targeted for those groups, and then actually look at the data again to see if the interventions had any effect. So this was really just the first try at this sort of whole timeline of identifying, doing the intervention, and looking back. And then they didn't see a lot of difference, and I don't think they expected to this first time around. They wanted to refine their methodology, but they've shown that this type of technology can actually be very useful for these types of very common public health interventions. And I could certainly envision some questions around STD prevalence and other types of questions that might be available in an electronic health record for us to aggregate information by risk factors or demography that's in the EHR that we might not have through all of our surveillance reports to actually help identify what's going on in our community. Or maybe there are issues, preceding STD risk where we could ask questions through the EHRs as well. And again, this is one of the areas where we really need the input of groups like this to help define exactly what it is that we'd like to do with data access framework to make sure that as we mature the standards and start publishing certification criteria to ensure that vendors can interact with us, that they're actually able to do it. And then finally, the third set of standards that I would like to talk about is called Healthy Decisions. And it's really about providing clinical decision support as a service. So much like structured data capture was offering a form as a service, Healthy Decisions is offering clinical decision support as a service. So this is where the EHR product could send some basic information about an individual and get back some public health specific recommendations. So I've seen some really cool apps where you can have a personal health record with your information. You could put everything in about yourself, and it could come back with a public health risk profile about screenings that you should have had and other types of public health type interventions that should be going on based on your current history. But instead of having to do all of that manually on an individual basis, services like that could be integrated through standards directly with an EHR product so that EHRs could get back specific recommendations from public health. And I think it's not only useful for things like preventative care, but I know in the STD world, as services are moving from being provided directly by health departments to being provided more in the community, there's concern that maybe the right drugs aren't being prescribed all of the time. People don't know about the resistance patterns in their community. This is the sort of thing where clinical decision support as a service could really help play a role, where public health could own that clinical decision support service, could update it in real time so that whenever a provider called upon that service at the public health department, it could get the most current recommendations for treatment. So I think there are a lot of really interesting ideas here as well across many public health domains prevention and treatment, where public health could provide a really interesting role in getting clinical guidelines and clinical decision support directly to the provider at the point of care. So I think John's going to probably cut me off fairly soon, but we do have some really exciting pilots planned around clinical decision support as a service. One of the things that we're looking at is letting an EHR product know when something is reportable. That's actually a very tricky thing to know, depending on what jurisdiction you're in, what's reportable within your community. So there have been some really interesting rules built around that. There have also been some interesting rules around immunization forecasting. So I think there are a lot of great things that public health could do in this arena. And it could also tie in with some of the other initiatives that we talked about. Clinical decision support could tell you when something needs to be reported, and that could trigger a structured data capture form to do the reporting. Or if someone comes in and the clinical decision support encourages them to ask current smoking status, and the answer is that they're currently smoking, there could be a second clinical decision support reminding them to refer to smoking cessation programs, and then you could actually do an electronic referral to that smoking cessation program, again, with a structured data capture form. So I think there are a lot of really exciting things here that could happen, but we really need to describe them very well and document them so that we can make sure that the standards can handle all of the things that public health would like to do. So just a little bit about how you guys can get involved. We do have our Public Health Tiger Team, and if you Google Public Health Tiger Team ONC, you'll be brought right to that page. And we meet every Tuesday from 2 to 3. We've got great partners at CDC who are actually leading the call today since I can't be on. And I would really encourage some people from the STD community to join. It's an open forum. We call it a duocracy, people who show up and do the work. That's what our focus ends up being. So we really do need more people from the STD domain there. We welcome vendors both on the EHR side and on the public health system side as well. We'd love to see some of the jurisdictions who have some really great products that they developed bring their public health vendors in as well. Some of the other things that you want to think about are partnering with your state Medicaid agency. Whenever you're doing things for certain activities for meaningful use, there's always an opportunity to get some reimbursement through Medicaid. And the other really exciting potential for funding there is the state innovation models. I think tying some of these in with quality measures and state innovation models could allow public health to potentially build some infrastructure to do some of these as well. And one last point, if there are some folks out there who are still public health departments providing services, there are meaningful use incentive dollars out there and available to implement electronic health records as a provider. You do have to have a certain volume of Medicaid or Medicare to be eligible for those, but there is a new clause in the rule that says even if you aren't being paid for those claims, you can still count them towards your volume to be eligible to get the meaningful use incentive dollars. So there's, I think, depending on your particular public health department, there are lots of potential ways to get involved and to look for funding. And I think I will end there because I'm just about out of time. But
Jim,
definitely feel free to. Yes, go ahead.
Jim, thank you so much. That was a wonderful presentation and offered a lot of exciting and interesting possibilities. Maria, could you let people know how they can ask a question or comment at this point?
Sure, John. Hi, everyone. You can type in your questions on the chat box provided in the web room. If you also dialed in using your phone, you can press #1 on your phone keypad, and then I'll be able to unmute your line so that you can ask your questions. Thanks very much.
So Jim, maybe I'll just start while we wait for people to ask questions. I'll just ask you a quick question. For a smaller health department, it could be a state health department or a local health department. These initiatives might seem exciting, but it might be difficult to understand how they, as an isolated health department, could become involved in one, given lack of resources and whatnot. Is it helpful for groups that are or health departments that are interested to work, say, through ASTHO or NACHO, as opposed to contacting you directly? What's been your experience about that kind of mechanism for involvement?
So I think that's a great question, John. And I think for developing the stories of what public health wants to do, we want both large and small. We want the variety of health departments as part of our public health tiger team to make sure that we're documenting everything that people would like to do. But when it comes time to build the infrastructure to actually accomplish some of these, it certainly doesn't make sense for every health department to build all of this on its own. And one of the great things that ASTHO has done in conjunction with CDC is start developing what's called the Community Public Health Platform, where they're trying to build services in the cloud that could be utilized by health departments to actually help support some of these initiatives. So our Public Health Tiger team has a really close tie-in with the Community Platform Cloud at ASTHO to make sure that they're starting to think about building some of the services that are important to public health that we've uncovered in our Public Health Tiger team. And if you're not involved in ASTHO, and if you're not involved or with ASTHO or NACHO, definitely get involved with their informatics groups, because they're the ones, and it is both ASTHO and NACHO supporting this cloud, that are really helping to find how those services are built to support the local health departments.
Terrific. Thanks, Jim. Maria, are there calls or questions?
Hi. No questions just yet.
Okay, great. So, Jim, maybe I could ask you to give an example where you think that with one of those exciting initiatives, you could imagine a new initiative that would have a specific STD focus to it. Maybe for example, on the last clinical initiative that you talked about, the access to clinical expertise, we heard from those 10 teams I referenced earlier that there was sometimes concern that if local and state health departments were reducing the local and state-run STD services, some clinical expertise might be lost. Can you see a mechanism whereby that clinical expertise might be provided in the mechanisms that you provided through the community health centers, but with linkages to expertise that existed in the health department?
Sure. That's a great question. And I think what we'd want to do is figure out what kind of recommendations it is that we want to make sure that the people who are providing the services at the point of care need to have. So that's the first thing we would need to do. And then once we've determined what that is, and let's say it's something around treatment guidelines, we would work very closely with our group at ONC around standards to put those recommendations into a very specific technical language so that the EHR products could interface with that public health clinical decision support tool and really receive in real time those guidelines. If you think about how EHR products work, as you're using them, pop-ups come up with the clinical decision support. And if someone were to enter a diagnosis of an STD, instead of relying on a pop-up that came up directly from the EHR would call out to public health and say, what are the current treatment recommendations? And then that would come back in a standard way, and that would be the pop-up that would be viewed at the community health center or the local provider, the current guidelines that are coming directly from the public health department.
Thanks, Jim. We have a couple of other questions that have appeared on in the chat room. The first one is if you could talk a little bit more about the ASTHO Community Platform Cloud that you mentioned. In part, that's because the CDC STD division is interested in developing cloud-based apps that includes their guidelines. So
yes. So the ASTHO, currently funded from C-Cells, is developing what they're calling a community-based platform where they're trying to understand from the local health department what sets of services might be useful to them that they might not have the resources to build themselves. And I think clinical decision support is an excellent example where something like that could be built centrally at ASTHO, and then the jurisdictions could put into a more generic rules engine what are the specific treatment recommendations for them, because I think that some of those might vary jurisdictionally depending on resistance patterns. And so when a health department put that information in specific to them, there could be maybe 10 or 15 different treatment recommendations for the same STD that vary based on geography. But then when an EHR vendor called out for that clinical decision support, geography would be part of the information that's shared with that clinical decision support service to know that I'm in Tennessee, what are the current recommendations for Tennessee, and it would get back the right recommendations. But it would really allow for one central place for us to focus our efforts on building this new technology so that not every public health department has to build it itself. And the other really nice thing about that is it makes it easier for EHR vendors to interact with a central location instead of having to build 50 different interfaces. But that's work that's going on with ASTHO now, funded by C-Cells, and we would love to see, I think, more cross-domain activity in that arena across the various domains at CDC.
That's great. And maybe one final question, Jim, is, some health departments are so small that they would not have the EHR or the capacity to implement an ELR. And so is there, for a very small department or a department that has very limited resources, is there an action step that you would suggest as a starting point for taking advantage of some of these opportunities?
Sure. So I think if we're talking about public health as a receiver of data, and ELR is a great example, if we're talking local health departments, I think this is a case where it's always a good idea to try to partner with your state and also look at what activities the platform might be able to support in the future for you as well. I think receipt of reportable conditions and things like lab reporting are some of the things that they are considering, but they need to know that that is a need. If they're a small health department that's acting as a provider and they're looking to start an EHR program and to actually have an electronic health record to support their provider-based services, I think one of the first things that they would want to do is reach out to their regional extension center. Almost all of our regional extension centers are continuing their grants on a no-cost extension, and public health as a provider is one of the priority groups that we've asked them to work with. So the regional extension centers should really be there to help with implementation of electronic health records. Depending on the Medicaid volume that they have, there could be incentive dollars available, but even without incentive dollars, our RECs are there to help figure out what EHR products to purchase, how to implement them, and how to transform from paper-based to electronic-based practices.
That's great. So, Jim, just in summary, correct me if I'm wrong, it sounds like 3 places for those on the call that might be interested in getting involved would be either the ASTHO or the NACHO committees that are working on HIT-related issues in informatics, the Tiger team directly through the mechanism you mentioned, or at a state level, contacting the HIT team that's been established at the state level to work on issues of meaningful usage and other HIT approaches. Did I accurately summarize the three different places that people could move to get involved?
Yes, definitely. And there, in addition to sort of the state HIT teams, there's also, in a lot of places, are regional extension centers as well.
Great. Well, thank you again, Jim. This has been incredibly helpful, and we really appreciate the work that you're doing at the ONC that supports public health and makes it possible for local and state health departments to be so directly involved. We really appreciate that.
Thank you.
At this point, I'd like to introduce our next speaker. In this presentation, we're going to be looking at a pilot where a local health department implemented an automatic data exchange. We're fortunate to have Dr. Rebecca Gluskin present the terrific work that's gone on in New York City. But first, we will hear briefly from John Abellera. Mr. Abellera is a health scientist for the National Electronic Disease Surveillance System at the CDC. He too has had experience at the local level in a health department. Early in his career, he worked as an epidemiologist for the Pinellas County Health Department in St. Petersburg, Florida, and the Georgia Emerging Infections Program in Atlanta, Georgia. And more recently, and prior to joining CDC in 2007, he served as a senior research analyst for the Council of State and Territorial Epidemiologists. John is going to introduce Rebecca and give a brief introduction to the work CDC is doing to develop pilots like this. John?
Thank you, John, and good afternoon. For this part of the webinar, my colleague Rebecca and I will provide all of you an update of our work to enhance public health access to timely surveillance information of public health case reports, also to refer to as confidential morbidity reports, or in STD vernacular, the 3x5 yellow morb card. Public health case reporting falls in line with the principles of structured data capture initiative, as Jim had alluded to. And this initiative serves as a means to define what is important to public health by sharing surveillance use cases. And for the example, communicable disease surveillance, to help define data standards and processes to get the information from an electronic health record system and pre-populate the necessary public health case report form, and in this case, the sexually transmitted infectious disease.
John, can I
Yes.
interrupt you just for a second? It appears that we may be having some technical difficulties with the phone call, and I just want to check in with Maria. Maria, we're hearing on the chat room that a number of the participants say they no longer can hear sound.
Yes, I've reconnected the line for them to be able to hear it, and I believe it's now working again.
Okay. So for those of you who have lost sound, very sorry about that, and we'll pick up now. The person that you're hearing, that you will be hearing in just a minute, is John Abellera, and John is is a health scientist for the National Electronic Disease Surveillance System at the CDC. John, sorry for the interruption, and please continue where you were with your presentation.
No problem. So as I was mentioning, that the work that we're doing is to enhance public health access to timely surveillance information of public health case reports. And what I had mentioned is that in STD vernacular, this is likened to the 3x5 yellow morb card used to report a case of a sexually transmitted infection. So the public health case reporting falls in line with the principles of the structured data capture initiative, as Jim had alluded to. And this initiative serves as a means to define what is important to public health by sharing the surveillance use case, and for example, the communicable disease surveillance use case, and to help define data standards and processes to get the information from electronic health record system, pre-populate the public health case report form for a sexually transmitted infection, and to send to public health. I'd like to recapitulate the data flow that Jim had mentioned early in his talk. And I think it's important I provide context of public health case reporting as part of the data flow in the larger enterprise of the National Notifiable Diseases Surveillance System. Beginning on the left, public health reporters are required to send lab and case report of reportable conditions to state, territorial, local, and tribal public health authority. The data is received by public health in different ways, and for public health case report, it is received by phone, fax, web-based data entry, and in most cases by paper. This is a huge burden for both the provider, infection control practitioner, to take the time to report, and by the public health practitioner who has to enter the information into their surveillance application. But also, additionally to this burden, is the follow-up exchange between public health and data providers to retrieve more information. And as we move in this paradigm shift from paper to electronic case reporting, how do we leverage electronic health record systems to facilitate timely, complete, and contextual information? And how we further share timely surveillance data with CDC programs like the STD program through case notifications. And this is represented by the data flow from the state health departments to CDC. As we think of the NNDSS enterprise and work to increase interoperability between the various information systems in this ecosystem, it is important that we are aligned with CDC's surveillance system strategy, which aims to guide efforts to make essential surveillance systems more adaptable to the rapidly changing technology landscape, more versatile in meeting demands for expanding knowledge about evolving threats to health, and more able to meet the demands for timely and population and geographic specific surveillance information. And we try to accomplish this by working with the Office of the National Coordinator to define standards-based vocabulary and code sets, and understand and recommend the structure to securely receive and process electronic public health case reports through the ONC and initiatives like the structured data capture. The public health impact of our work is intended to promulgate data and IT standards across health jurisdictions and programs within the public health department, as well as increase interoperability between EHRs and state electronic disease surveillance systems, but also between public health information systems within a jurisdiction. All of this is expected to reduce the burden on public health and clinical practitioners, improve timeliness, completeness, and contextual information relevant for identification, control, and prevention. Now I'm going to transition the slides to allow my colleague Rebecca Gluskin to present on a pilot project funded by CDC to demonstrate public health case reporting from an EHR system to the New York City Department of Health. So without further ado, I will introduce Rebecca. Rebecca Gluskin serves as the Director of Data Linkage and Business Intelligence at the New York City Department of Health and Mental Hygiene. She holds a PhD in epidemiology and was a 2012 Applied Public Health Informatics Fellow.
Great. Thanks, John, and thanks, Jim and John are back as well. So I'm going to speak to you about the pilot project that we worked on this last year here in New York City and talk about its successes and its challenges and potential next steps. So currently in New York City, providers are mandated to report. They report, as we said, through fax, mail, and New York City also has an online application called Reporting Central. This is an in-house developed web application that sits outside of the EHR. So the reporter needs to log into a separate website in order to report electronically. So challenges with this form of reporting is that although the data we need exists in the EHR, the provider has to go outside of their system to enter into New York City system. And this leads to issues with missing, late, or incomplete reports. So working with CDC, CST, and NACHO on a pilot grant, we were exploring opportunities for EHR reporting. So the question was, how can health departments leverage the information in the EHR system without re-entering data into our in-house Reporting Central? So as you know, there's hundreds of EHR vendors with varying systems and data fields, and it's really a challenge to navigate them as one health department. And on top of that, EHRs don't want to have to navigate multiple jurisdictions reporting. So it's a exponential problem that we wanted to try to solve. So what we did was we leveraged and aligned with meaningful use initiatives and some great documents provided by the CDC. So a little background on the project. The goal was to pull data from the EHR, and what we call it, and would be the information is stored in what we call the clinical data architecture. It's called the CDA. Now that is housed, all the information. Within that is what we call the continuity of care document, the CCD. And then from in that document is the data that we would want to use to report a disease report. So this is the structure that the data is contained in the EHR. So what we really wanted for this pilot was to pull patient demographics, provider and reporter demographics, and some disease detail. So working with these documents, specifically the CCD, we mapped our data fields in Reporting Central to the CCD and found about 70% of the common fields can be mapped and automatically pulled. So this is a high-level workflow summary. On the left is the provider. So the provider is in, or the reporting nurse is in the EHR, and they need to click on a link in their system to report to public health. What this action does is it then triggers on the Department of Health side to return a form back to them that will help them fill out the information we need. The reporter or provider fills out the information, then sends it back to the Department of Health, and then we receive the data we need and send them a confirmation that they've reported. And this all happens seamlessly within their EHR system. So using the analogy of PayPal in a shopping site, they don't have to leave the site in order to report to public health. So this is a more detailed data flow, and just so you can get a better idea of where and how the data is stored. So we partnered with the vendor Epic, which is a large hospital vendor, and they were able to help us understand how to work within their system. So what we did is we placed a link inside Epic's system where it says report to public health, and that's where the provider can click in their EMR, and that action sends their continuity of care document to the Department of Health. That's the orange polygon in the bottom. So in that orange polygon is the forms manager, and that's where all of the hard work goes on. So that's where we've done the process of mapping CCD to the data fields that the New York City Department of Health needs. We then return to the EHR window what we think mapped to the fields we need. And I'll walk you through that in a minute. So then the provider can review the data that they're submitting, make any corrections or updates, and then they send it back to the New York City Department of Health as a report. And we store both the corrections and the original document for auditing purposes. So this is a hypothetical screenshot of an EHR. It's not Epic's, but you can see where the green arrow is would be where the provider would need to click on to report to public health. So what was out of scope of this project was the trigger. We didn't create any triggers for public health reporting. The provider needs to know that the disease they're seeing is something that needs to be reported, which is how it works right now with our in-house Reporting Central or sending a fax or making a phone call. So they click on that link, and that takes them to our New York City developed page. And that action of clicking has already pre-populated all that nitty-gritty demographic work that people hate to fill out multiple times. So it's auto-populated patient name, birth country, address, which eliminates a lot of the missing data and room for error that can happen when reporting to public health. So the provider just clicks through, confirms that we're pulling the right data, and then what they are then able to come to is the disease condition section. So in this case, our pilot use case example was pertussis, but as you can see, we're also working on HIV partner notification services. So this is something that a normal EHR doesn't have built into their software, but that public health really wants to make automated. So I can talk about that later, but right now the example is pertussis. So the provider selects the disease they're reporting, and then the system pulls what it can, but also leaves fields open for the provider to add more information. So in our case, the only information that was automatically pulled from Epic's system was that the initial date of diagnosis. So we wanted more detail. We wanted to know whether the patient had a cough, the dates of onset, all this information, where the provider can just quickly tab through and enter the information that public health needs. And then finally, what's automatically pulled is the reporter information and the provider information, so that public health can go and reach out to them if we need more data on this report. But it relieves the burden of re-entering data, which exists now. They click through and they can review what they're about to send to confirm that it's what they want to encompass the report. And then they receive the confirmation number, and with continuing the pilot, we want to send them back an actual document saying they reported to public health. And further, what we would hope would one day occur at this point is information from the health department. So notices on specifically pertussis, any advice that they can give to the patient, and so on. So there were a bunch of lessons learned as we worked with Epic on this project. So we learned that working with the EHR vendor was really important, and that securing that partnership was crucial to its success. Otherwise, we would have been creating something that wouldn't integrate into another system. Another challenge was that interpreting the fields in an EHR document is challenging, and translating them to public health is even more so, because EHRs are not necessarily developed for public health reporting, so there's a lot of nuance that goes into reading those fields. And finally, we learned that partnering with an off-site clinical practice to test its message transmission is really important, because it's going to be the provider that's using this tool, and we really want to understand how this fits into their workflow. But there were some great successes. So what we didn't have to do was figure out how to report, because we already had our online reporting central application. So that work has already been done for us. We found that integrating with this in-house tool was a great way to leverage forms really quickly. So we already have all the logic for all of our reportable diseases online. We just have to figure out this way to integrate with EHR. We also found the CDC's resources really helpful. So the structured data capture document that both Jim and John are talking about was valuable to understand how EHRs work. It's a whole new language for public health, and it's sort of like the Rosetta Stone. And then finally, this pilot was done in collaboration with our other grantee counterpart in Wisconsin. So the state of Wisconsin actually developed a very similar system to work with Epic. So we were able to demonstrate that two jurisdictions, Wisconsin and New York City, were able to integrate with one EHR vendor, Epic, showing that this form of reporting is dynamic for multiple jurisdictions. So a few next steps. We'd like to continue to streamline the workflow for providers. And that means working with providers in their setting to understand how they report to public health now and what would be the best way to integrate into their EHR system. We'd also like to incorporate resources for the provider into the application. So as I mentioned, not just taking data from the provider, but we want to give them back information that they can use in their practice and give to their patients. So in the case of HIV partner notification, we'd like to streamline that process so that providers can give us the information that public health needs to work with partners on, work with patients on partner notification. And we also want to expand this to the first episode of psychosis reporting. So we presented this pilot to the New York City Association for Professionals in Infection Control and Epidemiology and Institute for Family Health, which does a great deal of STD reporting, and they have further further requests that they would like to pre-populate info from the EHR and store the case reports in the patient's medical chart. So they want the patient to know that they've been their case has been reported to public health as well. So, well, you know, great new additions to this, and we continue to seek further feedback on this application. And that's our slide. So that was my last slide. And open to questions about the pilot. So yeah, Maria, if there's any questions, let me know.
Thank you very much, Rebecca and John. And Maria, would we turn to you to reopen the lines for questions?
Sure. Once again, if you have dialed in, just press #1 on your phone keypad, or you may also just type in your questions through the chat box. Thanks very much.
And Rebecca, while we're waiting for that, you mentioned that there was that part of the pilot, or the next stage of the pilot, was the HIV partner notification. Can you just give us a little bit of information about whether you think that will follow the same direction as pertussis, or will it create different kinds of issues and challenges?
Yeah, that's a good question. So that was as soon as we presented this to the department, HIV was immediately interested in partner notification because that is somewhat underreported, and to have it within the EHR would be a great way to really catch the partner notification chance of where it happens. So it would be a dynamic form where we would be capturing information that's not found in the EHR. So it's information on the contact information for partners, how to reach them. So these are all things that are not found in the EHR, but so you couldn't automatically pull it, but it's really important for our reporting here in New York City. So that would be a next step. We're sort of waiting on funding from a few sources, but I think it's definitely a direction we're going to go.
Well, that's great. I think we're going to be interested in seeing what you find out from that. There is a question that has been sent electronically that asks in your, I think you just a few minutes ago mentioned that that you would be working on pre-populating the information from the EHR, and the writer says that they thought that the pilot already did that to a certain extent. So is there additional pre-population that of the forms that is anticipated?
Yeah, so the person asking the question is right. So to a certain extent, we were able to pre-populate the form. So about 70% of the information we needed, specifically demographics, patient demographics, provider demographics, and a little bit of disease information. But because health departments want a lot more detail than what's provided in the EHR, we have to make some of it manual. So what the providers were asking is that they want more automatic population. So it would just require more mapping, drilling further into the EHR, not just grabbing that continuity of care document, but then getting out to that bigger EHR system. So it's a little more challenging, but it sounded like there was a demand for that.
That's great. Thank you. Another question is that has been sent electronically is, are there plans to push out the tool that you've used so that providers know how to use it, or will you try to build CDS in order to get people to use it?
So right now we would really want to work with the stakeholders, the providers directly, to understand how it needs to be fine-tuned. This is sort of put together as a pilot, but we haven't really implemented it in an actual workflow. So we still need to work with Epic and a pilot provider site to see where the gaps are. So we're not quite at the stage to push it out yet. So hopefully soon, but I think we really need to make sure that it's going in the right place in their electronic health system.
Thank you. Maria, are there telephone call questions?
None from the phone.
Let me ask one additional question. Is you had mentioned that there was that this was making reporting easier. Was there evidence that the reporting was perhaps more accurate or captured additional cases that wouldn't otherwise have been reported, or that the reporting was made in a more timely way as a result in the pilot?
Yeah, so in the case of pertussis, which is what we were testing, we typically receive a lot of reports through laboratory reporting, which can have a few days delay. So this would be this could be an initial report prior to the lab report. So it could, if it was a suspected case, it could be a couple of days before the lab report comes through. But of course, it won't have the lab data in the report, so the ELR report would then be a sort of confirmation. So yeah, as a pilot, we were sort of assuming that this would come before the ELR report, but in practice, we haven't yet seen how this works.
And Rebecca, is this in the pilot? Could you use it with any other systems other than Epic, or was Epic the only one with which you could connect?
That's a good question. We actually started working with a different vendor and had to switch halfway just for logistical reasons. But this is being designed as a web service. So as long as the other vendor has the specs, the specifications that we were given from IHE, that they would be able to design to the specs that we use. So we weren't building this specifically for Epic. They just happened to be the vendor that decided to work with us. But it's really being built as a general application.
Terrific, thanks. So Maria, I'll check in with you one more time about whether there are folks who have indicated a desire to ask a question. And maybe I would also offer to the participants, if there are questions that you now have for either John or Jim, feel free to relay those as well at this point.
Hi, John. So far, none from the phone lines, but I do see someone still possibly typing a question in the web room.
So thank you for that. I think while we're waiting to see if there are any final questions, I'm going to mention two things. First, I want to especially thank Dan Lentini from the Centers for Disease Control, the STD program, for his support and guidance throughout this webinar and the other activities that we have undertaken to encourage the consideration of integration of STD services into primary care. And finally, before we hear if there are any other questions, I want to remind people that Friday at 1 o'clock Eastern Standard Time, we will have that second webinar I was mentioning. And again, the topic of that one is taking the steps necessary to guarantee confidentiality of the provision of STD services in primary care. And that in part was looking at adolescents in particular, where we heard that adolescents might be reluctant to seek STD services in a primary care provider setting if they were worried that their parents or the holder of the insurance card would be notified through a explanation of benefits mailing. We heard that was a real concern among local and state health departments that had previously provided services for free. So we have two experts that will provide us with information about both changing policies or programmatic ways of addressing that concern. Again, that's Friday at 1 p.m. Eastern Standard Time. And if you haven't already registered, everyone on this call will be receiving a reminder notification of how to register. Thanks. Now, I do see that there are a couple of other electronic questions, so I'm going to just read those. I think this is an open question for Jim, John, or Rebecca, but maybe more for Jim and John. That is, will there eventually be a requirement for uniformity of various reporting forms across jurisdictions for reportable diseases? Jim or John, would you like to comment on that?
Yeah, this is Jim, and I'll start, and then maybe John would like to chime in too. One of the things that we are doing with the Public Health Tiger team when we're going through our structured data capture portion is to try to encourage everyone to ask the same questions the same way, but not necessarily have exact conformity across all jurisdictions for all reportable conditions, because I think, as we all know, there are always things that are important in some states that may not be as relevant in other states, and we need to allow for some jurisdictional variability. And I think one of the great things about structured data capture is that it does allow for that, because different states that have different forms that are being called, even if we had a completely centralized forms manager hosted at ASTHO, part of the logic for what form you got back could be the jurisdiction that you're reporting from. So there could be a couple of extra questions that come back if you're in Louisiana or Mississippi versus Massachusetts. There could be some differences there. But the thing that we're trying to encourage within the structured data capture team that's working on this for public health is, if we are asking the same information, let's ask it the same way, and let's use the same standards for asking it. And that's especially important for the pre-population piece. John might want to add on to that as well.
Yeah, Jim, I think you're absolutely right. And just to mention on our earlier work here at CDC and working with the Council of State and Territorial Epidemiologists, we did review a series of confidential morbidity reports, and a lot of them did ask the same question, but they asked in a very unique way. What that was, I guess, the representation of those data elements were slightly different. So as we try to standardize that and make those recommendations, we hope that each of those jurisdictions will take those recommendations for a more standardized way of asking these questions.
Thank you. There's an additional question, and this one I think is to John and Rebecca. It says that I think, John, you mentioned that you were moving to a cloud-based system, and the question is, was the pilot that you mentioned, and I think that refers to Rebecca's pilot, cloud-based? And in addition, it asks just for a little more clarity about Epic and how that functions, and whether, I presume that the question is whether or not that easily functions via the cloud. So John or Rebecca?
So this is Rebecca. We did not use the cloud for this pilot because right now New York City is not using the cloud, but we will explore it. For now, we think that we won't need it if we keep the audit trail fairly light, but maybe John can answer more broadly the use of the cloud for other pilots.
Yeah, for this, the intent was not to use a cloud-based environment. Now, maybe this is the question that was, I think, posed in Jim's presentation. But the idea is, how do we potentially leverage web-based services that, like a form manager? And I think that's maybe where part of that discussion had come up with using the cloud. But for this pilot, it was only focusing on making those connections. And however, New York City or the other jurisdiction that was funded for this was Wisconsin. Is there a surveillance application in the cloud? I think those are some of the things that could be leveraged individually at the jurisdiction, but for this pilot, we did not focus on that.
Jim, with regard to this, is there something you would add as well in terms of the longer-term planning?
Sure, and the standards are being built to where this could work in a cloud-based environment with centralized hosting, or in an environment where a public health jurisdiction is hosting it in their own, like New York City did with the pilot. And the same runs true on the EHR side as well. I think part of the question was whether or not the EHR product was cloud-based as well. And Epic is generally not cloud-based. Some of the EHR vendor products out there are. Epic generally is not. But again, these standards really work independent of whether or not we have local installations or cloud-based installations of the products or services.
Great. Thank you for those answers. Maria, just checking one last time with you about whether there's anyone in the queue.
None at the moment, John.
Okay. Well, so I want to close by saying thank you to everyone who has participated. A special thank you to Jim, John, and Rebecca. And also, let me express one more time our gratitude to the Association of State and Territorial Health Officials for your support in developing this webinar and the following one on Friday, and to CDC for its ongoing support in conjunction with the other partners that have participated in this effort, NACCHO, the National Association of Community Health Centers, and the National Coalition of STD Directors. So thanks to everyone who's participated. We will be posting the tape of this webinar on the ASTHO website, and one person asked as a question whether or not that would be possible to download. We're not sure about that now, but we'll investigate. If you go to the ASTHO website, you should be, once it's posted, it should be clear whether or not it's downloadable. If not, we will try to create an alternative forum where the slides may be made more accessible if it's not possible through the ASTHO website. So again, thanks to everyone, and hopefully we'll have you all participate again on Friday. At this point, the webinar is over.